All right, let's jump right in. In this explainer, we're going to build a really practical, step-by-step framework for one of the most common hematology problems you're going to see, immune thrombocytopenia, or ITP. Let's get to it. Okay, picture this. You're in clinic or the ER. A 34-year-old, totally healthy otherwise, comes in with some new bruises. The labs pop up and you see it, a platelet count of 19,000. Yikes. This is a classic bread and butter scenario, and what you do next is absolutely critical. So we're going to build your approach from the ground up, starting right here. So here's our game plan. We'll start with how you approach any patient with low platelets. Then we'll get really clear on what ITP actually is. After that, we dive into the workup, the real meat of it, and learn how to spot those dangerous lookalikes. And finally, we'll pull it all together so you can make the diagnosis with confidence and walk away with a checklist for your next shift.
Look, our goal here isn't to just have you memorize a bunch of facts. It's to build a systematic, repeatable approach that you can use for any patient who walks in the door with a low platelet count.
So what exactly is ITP? At its core, it's an autoimmune thing. Your body is making these autoantibodies that are basically tagging your own platelets for destruction. And to make matters worse, they can also gum up the works in the bone marrow so you don't make as many new ones. The official cutoff we use is a platelet count under 100,000.
Now, getting the terminology right in ITP is actually pretty important. It's not just semantics. It really helps you classify the disease and communicate clearly with your colleagues. So let's break down the key terms you'll hear.
Okay, first big distinction. Is this primary or secondary ITP? Primary ITP is when it's happening all by itself, for no other clear reason. But secondary ITP, that's when the low platelets are a symptom of something else going on, maybe an infection like HIV or Hep C, or another autoimmune disease like lupus. And this is a huge deal because if you treat that underlying cause, the platelets will often get better on their own.
We also classify ITP based on how long it's been going on. So, for the first 3 months after you make the diagnosis, we call it newly diagnosed. Pretty straightforward.
Now, if it sticks around past that 3-month mark but hasn't hit a year yet, the term for that is persistent ITP.
And once it's been present for more than a year, we officially classify it as chronic ITP. And this is really common in adults. Unlike in kids where often just goes away, in adults it frequently settles in for the long haul.
So this just puts it all together visually. You've got newly diagnosed, persistent, and chronic. Knowing these stages is really helpful for framing those conversations with your patients about what they might expect down the road.
All right, now we get to the core of it all, the workup. How do we actually diagnose ITP? Well, it all comes down to one single critical principle.
This is it. If you remember one thing from this whole explainer, make it this. There is no blood test that screams, "This is ITP." You make the diagnosis by being a good detective, by systematically and confidently ruling out everything else that could be causing those low platelets.
So what does that detective work actually look like? Well, it rests on 3 main pillars. First, a super detailed history and physical. Second, and this is completely non-negotiable, you have to review the peripheral blood smear with your own eyes. And third, you've got to screen every new patient for HIV and hepatitis C.
So let's really focus on that second pillar, because the peripheral smear is your most powerful tool right at the beginning. When you sit down at that microscope and look at the slide, what are the key things you need to be actively hunting for?
Okay, so first up, you're looking for big clumps of platelets. If you see those, you can breathe a sigh of relief. That's pseudo-thrombocytopenia. It's just a lab artifact, not a real problem. Next, scan the red cells. Are they normal or are they fragmented and torn up? These fragments are called cystocytes, and they are a massive red flag for a medical emergency called a TMA, definitely not ITP. Then look at the white cells. Are there a bunch of weird immature blasts floating around? That could be leukemia. In true ITP, the red cells and white cells should look pretty much normal. You're confirming it's an isolated problem with the platelets.
That deep dive into the smear leads us right into our next big step, building out that differential diagnosis and ruling out all the things that can pretend to be ITP. The list of things that can cause low platelets is, well, it's long, but we can group them into some helpful categories. Drugs are a huge one. Always get a good med list. We've already talked about infections. Big systemic conditions like advanced liver disease can cause platelets to get stuck in the spleen. And of course, you always have to consider problems with the bone marrow factory itself, like MDS or leukemia, especially if other blood counts are off too.
I want to pause on this one because this distinction can literally save someone's life.
A patient with ITP, even with a crazy low platelet count, can walk in feeling totally fine. But a patient with a TMA like TTP is usually critically ill. They are sick. And the single biggest clue to tell them apart is right there on the blood smear. If you see cystocytes, you need to stop thinking ITP and start making some very urgent phone calls.
Okay, so you've done all the hard work. You took a great history, you did a thorough exam, you reviewed the smear yourself, and you've ruled out all the big, scary mimics. Now you can finally, confidently make the diagnosis.
And you know what's great? After all that detective work, the actual criteria are beautifully simple. Is the platelet count under 100,000? Yes. Is it an isolated problem, meaning no major anemia or weird white counts? Yes. And does anything else from your workup point to another cause? No. If you can say yes, yes, and no to those three questions, you've got your presumptive diagnosis of ITP.
Now for a super practical question. Your patient's platelet count is 19,000. They have some bruises, but there's no severe, life-threatening bleeding. Do they have to be admitted to the hospital? What's the right call?
Well, the guidelines are actually pretty clear on this. For a brand new diagnosis of ITP, you should generally admit any patient with a platelet count under 20,000. That's kind of the magic number. Or, of course, if they have any significant bleeding, no matter what the count is. This is all about being safe, allowing for close monitoring, and being ready to start treatment quickly if needed.
We have covered a ton of ground. So to wrap things up, let's distill this entire process down into a simple, high-yield checklist that you can just run through in your head every single time.
Here it is, your ITP cheat sheet. Number 1, be a detective with the history. Number 2, never ever trust the machine alone. Put your own eyes on that blood smear. 3, screen every single new patient for HIV and Hep C. 4, make diagnosis of exclusion your mantra. And number 5, a little pro tip, resist the temptation to order those antiplatelet antibody tests. They're just not sensitive or specific enough to be helpful in making a routine diagnosis.
So we'll end on this thought. You've navigated the diagnostic maze like a pro. You're confident it's ITP. The platelet count is 25,000, but your patient feels great. They're totally asymptomatic. The big question now becomes, do you actually need to do anything about it? And that whole jump from diagnosis to management, well, that's a topic for a whole other explainer.